The Institute of World Affairs at the University of Wisconsin-Milwaukee presents International Focus, a weekly discussion of the people and events behind today's global headlines. Support provided by Milwaukee Public Television and the UWM Center for International Education. Now here's your host, Doug Savage.
Welcome to International Focus. There are an estimated 875 million firearms in the world today, 75% of which are in the hands of civilians. Each year, enough ammunition is manufactured to shoot every man, woman, and child on Earth twice. Across the globe, non-military gun violence accounts for hundreds of thousands of deaths each year. By comparison, the estimated death toll from the recent Ebola outbreak, which prompted worldwide panic, was just over 11,000. With gun violence increasing in many parts of the world, including our own community, some health professionals are taking a new approach, using a disease model to understand and respond to the crisis. Our guest today is a nationally recognized expert on gun violence. Dr. Stephen Hargarten is professor and chair of emergency medicine and associate dean for global health at the Medical College of Wisconsin. He has served as an emergency medicine practitioner for over 30 years. As a researcher, his interests focus on the intersection of injury prevention and health policy. Dr. Hargarten, welcome to International Focus.
Thank you very much.
Well, I wonder if we could start with just some sense of scale, both in our own community and globally, of gun violence.
Well, I think you framed some of the scales very nicely in your introductory remarks. There are so many deaths that are occurring on a regular basis here in the United States, and then you take that and expand that to other parts of the globe. It is an endemic problem, and then it goes into epidemic growth like we've seen in cities like Milwaukee, Baltimore, and St. Louis. So it's a global problem of significant burden.
And talk a little bit about the factors that determine whether or not, if we use that model, you are more susceptible to the epidemic or not. What makes you more disposed to being a victim?
Well, I don't know if it's fully understood about that convergence and about how risk changes, but we certainly do know a lot about the individuals at risk. They are in poverty, they are unemployed, they are employed in maybe nefarious activities as part of their day-to-day activities, and oftentimes they then seek this product, gun, for protection or for usage for their activities. But I think you have to also think about the fact that a lot of the firearm-related deaths here in the United States, 2/3 of them are suicides. And that burden oftentimes goes unnoticed when cities like Milwaukee and Baltimore struggle with changes in homicide rates. And so we need to continually think about the overall burden of firearm deaths, firearm-related deaths, as homicides and suicides, and a small percentage of unintentional events where a child finds a gun and discharges it, and the bullet kills themselves or another person.
So much is said about the policy related to guns, and if you're a proponent of more gun control kinds of legislation, you point to the fact that we have some of the laxest gun laws on earth. Other people will say there's not a great correlation between ownership of guns and these kinds of homicides rates, and point to other countries where, in fact, maybe the gun density may even be higher, but the homicide rate is. So what is the correlation between sort of the ownership, first of all, and homicide rate?
I don't know if there's any specific correlation that says if you have this, you will have a predictive outcome. There have been studies suggesting that if you have this product in your home, that chances are more likely that it will be used in a suicide or homicide event than in self-protection. Now, those are studies that are there. There are other studies suggesting that there may be some correlation with concealed weapon carrying and crime rates. A lot of back and forth debate, largely discredited, that nobody knows for sure the ultimate real effect of that exposure. From the way I and others look at this, the exposure is really one of the risk factors. Just think about cars. I just drove from Chicago. I had a significant exposure to the kinetic energy related to cars and car crash events that I was seeking to avoid. But I had significant exposure, lots of cars. So we know that if you have an exposure to this kinetic energy and relying solely on good human behavior, that's not enough. So what do? You create safer environments and safer cars to assure that broad strategic approach to reducing the risk of that kinetic energy release, or if it is released, that you won't be seriously injured because you've got other things that help protect you. We've seen that in the course of years of looking at car crash deaths as a public health issue, we've looked at all sorts of interventions. If you remember in the 50s, it was, well, drive more carefully, be more careful. And in the 60s, there was a paradigm shift of how we manage and look at this kinetic energy risk in cars, on our bicycles, and our roadways. And we shifted that attention to be solely behavior-driven to one that includes the environment and its design, the federal highway system, other systems of highways increasingly are safer and safer, and we look at the car. And that was largely driven, if you will, by the story of the Corvair, which was manufactured by General Motors with a design flaw. They knew the design flaw existed, and their response was, drive more carefully. And that shift, which created a National Transportation Safety Administration, that shift of public health, looking at it in a broader context, broadened the strategies that included behavior issues, behavior changes that we continue to work on, the strategies specific to the car, its safety designs, and the environment. Classic public health that's been applied to diseases for centuries. And I believe we need to more strongly put that model, frame gun violence, as a public health issue, as a biosocial disease that requires us for rigorous understanding of behaviors, like you started to talk about, rigorous analysis of the types and distribution of firearms that are getting into the hands of unauthorized individuals, 14-year-olds, 18-year-olds, 25-year-olds with a felon history, and environments in which it's more likely that nefarious activities may occur, environment where there's low jobs, few job opportunities, few educational opportunities that improve that so that the behaviors are influenced, the environment is improved, and we look at the types and distribution of firearms in our communities where it's legally able to be purchased by those authorized to be purchasing them, and those who are not don't get access to this lethal means of killing another individual or killing themselves.
Well, if you look at the gun homicide rates per 100,000, the U.S. as a whole is roughly comparable to places that we look at as much more riven by conflict generally. More or less, we're slightly higher than Pakistan, for example. We're comparable to the Democratic Republic of Congo and just under Iraq. So what is there about American society that puts us more or less, statistically at least, in the same boat as places that we associate with much more deep conflict?
It's a great question, and I think deserves a lot more research and better understanding. I was looking at a textbook. The title of it is called Social Epidemiology, and nested in the chapters there is a graph comparing the rates of perpetrators of homicides in Wales and England compared to Chicago. And the graph of when the perpetrators start to rise in terms of frequency is identical to both Wales, England, and Chicago, meaning 17-year-olds and 19-year-olds, whether they be in those two areas, have the same propensity for mischief, for bad behaviors that we need to do a better job of controlling. But what's so interesting about this was the difference in homicide rates. 30 times greater in Chicago than in Wales in England, suggesting, is there something significantly different in the environment that causes those rates to be different? Or one would argue the availability of lethal means of carrying out assaults or carrying out these kinds of things that we see happen in our community. So we need more of these comparisons and contrasts between cities here in the United States and cities in other parts of the globe, understanding what policies work that we may learn from, what policies are working here that would be exported to other places around the globe. Cities have got to get this right. Violence is an unacceptable biosocial disease burden, and if we don't get this right, cities are going to continue to suffer. There was a very, very well-written book about the cholera outbreak in London in 1850s, very pertinent to today's discussion with Flint, Michigan, where the sewer system in London, in this case, was woefully under-constructed, in no real good shape. And here London is suffering, a premier city, from cholera outbreaks. Can you imagine having a cholera outbreak in one of our cities? It's unacceptable. And London and other cities then start to look at their infrastructure for public health, safe water supplies. And that is so important for cities to get right. Globally, more and more people are living in cities. First time around 2008, 2009, more people are in cities than ever before. And so cities which have disproportionately higher violent homicide rates, need to get this right. Need to really look at and understand this from a perspective that helps them control it. Well,
you reference cholera. There was an almost moral or ethical component to how that was perceived at one point, was there not? I mean, you're obviously slovenly, you keep your home in disarray. Is there some of that, do you think, with the perception of who are the victims of gun violence, that somehow these are people who at some level almost deserve it?
Well, it's a great, interesting comment. In the 1800s, 1850s, we didn't know, the world didn't know that cholera was caused by a bacterium. It was thought to be you were not of the right religion, you were not working hard enough, you were somehow deserving of this fate. And it was late in the 1870s and 80s that Koch's postulates began to emerge with an agent of disease. And you find it, anthrax, cholera, tuberculosis was a major global killer for many, many years. Once you have that agent of disease, some of them accompanied by a vector, a mosquito, very, very pertinent to today's discussion with the Zika virus. And then you have the pathophysiology of this unfolding. We had understanding of it now, so instead of assigning some sort of blame or some sort of stereotypical response to this disease, we assign it to a scientific undertaking. We apply research methodologies and attack it vigorously with all possible tools. Think about the initial reactions to the HIV outbreak in the early 1980s, where it was thought to be a moral failing that you would have HIV. You somehow deserve to have this. While we then finally understood that this was a new virus that was attacking, was not so new, but it was newly emerging here in the United States, we applied scientific, rigorous methodologies with strong NIH support. And look what's happening to the HIV epidemic that is now more endemic, and it's being controlled not only in the United States, but globally. We're in the 1950s with our thinking about firearm homicides and suicides. We are thinking about it, well, it's not in my neighborhood, and yet it's in every neighborhood in Wisconsin that firearm deaths are occurring. And we need to open up our inquiry, treat it and examine it and frame it as it is a biosocial disease, and apply all of the rigorous scientific methods we can to identify behavioral interventions that work in the short and long term, interventions that look at the firearms safety characteristics as well as its distribution, so that we reduced unauthorized individuals from obtaining this from online where there's scant oversight, and environmental interventions that work.
Well, we're going to take a short break, and I want to talk more specifically about how you apply that scientific method as if it were a pathogen. But first, we'll take a short break and come right back.
The Institute of World Affairs presents our community with a range of public programs relating to global issues, U.S. foreign policy, and the world economy. For more information about the Institute of World Affairs, call 414-229-3220 or visit our website at www.iwa.uwm.edu.
Welcome back. We're talking about the gun violence in our community and around the world with Dr. Stephen Hargarten. Well, fascinating to apply this sort of disease model to this issue. Talk a little bit, first generically, if there is an outbreak of any sort, what steps do public health officials do to first identify it and craft a response?
We think about outbreaks that are, as I said, occurring now with the Zika virus, and knowing that it has a vector, mosquito, and it may flourish in certain environments, the strategies start to be applied immediately as to looking at the virus, a vaccination, looking at the vector, seeing if you can eradicate the mosquito through insecticides or introduce species of mosquitoes that can't carry the virus or can't reproduce. And again, look at the environment in which you can eradicate places where they breed. Again, as I mentioned, you apply that to car crashes, and you start to look at ways in which you can prevent or attenuate the energy exchange. And attenuating the energy exchange is really a very critical strategy, such as with seatbelts and airbags. You think about our investigation of firearm violence, gun violence as a biosocial disease. You first have to understand what happens when the bullet enters and penetrates a human body, and there's a temporary and permanent cavity formation. We actually went to the crime lab and looked at a bullet going through a simulation model for human tissue, noting these dynamic changes. The challenge is that these dynamic changes take place in less than 1/10 of a second. A lot of diseases take place, like infectious diseases, over days, weeks. Think about a heart attack. Takes place over hours. We can investigate that. We can intervene. In the challenge of gun violence, intervening at the moment that the energy released has limited potential. A Kevlar vest is a good example of that. And so that's why you see individuals in those circumstances wearing Kevlar vests. But we don't have a lot of other real-time interventions. We have trauma centers and rehabilitation experts picking it up after the energy has been released, when the individual is already now suffering from the bleeding, the fracture, the permanent severing of organs, such as spinal cords. So the challenge is, how do we reduce the likelihood of that energy being released in the first place? And one of the ways in which one could start to strategize this, and is currently available, is smart guns. Guns that are available only to the authorized user. And we have that product available right now being sold in Europe, where the gun is placed proximal to your radio transponder. It then engages the mechanism, and you're able to defend yourself and use it in that circumstance. When the gun is taken away by an unauthorized user, a criminal who's stealing the gun from you, a person who wants to use it against you, a child who might find that firearm not stored properly, can't use it. And that reduction in unauthorized usage, I think, has a significant potential for reducing firearm-related events such as suicides and homicides.
So in the early application then of this sort of medical model, I mean, for example, you may look at clusters and where people are being affected by a disease. Is that a good starting point for homicides with gun violence as well?
Sure, I think it's a great example of this being applied to suicides where there may be clusters appearing in depressed adolescents. We know that a lot of adolescents are periodically thinking, boy, I don't have a high self-esteem. They're not thinking that. They say, I'm not worth it. And they're contemplating this self-destruction act. But if they have, during those impulsive moments, access to lethal means, particularly with a gun, I can't intervene as an emergency physician. As I said, it's at less than 1/10 of a second. If they take pills, they may be sick for some period of time. That's where emergency physicians, toxicologists can intervene, reverse the drug that's been ingested, and the individual moves through this phase where they're despondent, they're depressed, they're anxious, and they move on to an adulthood that is productive. So access to lethal means has an independent value while we also strengthen the environment in which these kids are struggling with their identities or struggling with their friends, and we have help for them 24/7. And so I think it's that way of framing it increases our potential for addressing clusters, for addressing issues such as assaults happening one weekend and next weekend there's a homicide. Perhaps when we know that these assaults are occurring, we are able to proactively intervene for that next weekend. It's an interesting, again, global perspective. There's the Cardiff Model. The Cardiff Model was started in Cardiff, Wales, where the emergency departments began collecting information about where an event occurred that was an assault, not just the time and the method. So if you think about knowing that assaults are occurring on a Friday night clustered around these sets of businesses or this park, you can proactively start to plan on prevention strategies for that next weekend so that this doesn't erupt again. Applying those kinds of public health principles of epidemiology is, again, consistent with that biosocial disease model, and it helps us better understand the distribution of the events and identify ways in which we can intervene.
So where else has this biosocial disease model been used? I mean, is this a American response, or has it been used elsewhere in the world?
Well, I think what we have wanted to do is more specifically apply and frame it as a biosocial disease. There has been increasingly good, productive discussion that this is a public health issue, but I think by pushing that framing to a biosocial disease, we then better understand this is about kinetic energy. How do we reduce the risk of this kinetic energy injuring an individual, injuring themselves? How do we do a better job of understanding those dynamics rather than oversimplifying it to simply a behavioral issue? This is not simply a behavioral issue. This is far more complex.
And what about in our American situation, the ability to use federal funds to come up with that information? I mean, there was a long period where that was problematic, wasn't it?
Sure. It was challenging with the Dickey Amendment being introduced in the 1990s that really was a chilling effect of doing gun research, gun violence research. And it's that chilling effect that occurred in the late 1990s that reduced the availability of federal agency monies from NIH, NIJ, and CDC. There is a resurgence a bit to now start to have explicit interest in studying violence as a public health issue, framing it as I've been talking about, and we anticipate and hope that would be more, that these research dollars can be applied to this very, very challenging problem. So we understand behaviors better. We understand this kinetic energy as the agent of the disease and how we can reduce its likelihood of being released and the environments in which these events occur. By having a good, solid research agenda, not only are the researchers who are currently struggling to do this can do more, we also bring on a new growth of younger researchers who see this as a very, very important area, but see that there's research funding to help support their interests.
So we've got just about a minute left. Who should be at the table that's not currently?
I think that we should be continuously seeking input from all sectors of civil society. I think law enforcement is an appropriate, very, very important element of this. But social services, schools, fire, leaders of civil society. Can you imagine if there was an Ebola outbreak in the central city, in the suburbs, anywhere in this Milwaukee area, we would be wanting to control it immediately because of our wanting to have a city that's healthy and safe. And that's what we need to do, is all sectors of civil society coming together in short and long-term strategies. It's not going to go away tomorrow, but it has to be done in a way that is respectful and what is also science-driven. Well,
Dr. Stephen Hargarten, thank you for being with us today. Thank you for your work. To our viewers, we'll see you next time on International Focus.
For information about the Institute of World Affairs and its many programs, or to become a member of the Institute, call 414-229-3220 or visit us at our website,